There are many possible complications of endocarditis: valve perforation, rupture chordae, myocardium abscess, annular perforation, purulent pericarditis, fistula, embolism, mycotic aneurysm, and recurrence. Let's study initially the abscess. It may form in any heart region, but is very frequent in this region posterior to the aorta, close to the interatrial septum. But any thickening of a heart structure seen in a patient with endocarditis is enough to suspect the presence of an early abscess. In an early stage, it looks just like an abnormal thickening of the involved region with a dense aspect. With its evolution, this dense area turns echogenic in its interior due to liquefaction. Then it may turn totally liquid in its interior, usually due to rupture of the abscess into the circulation. Occasionally, rupture to different places, producing fistulas. In this transesophageal echo, you notice that same region posterior to the aorta, at the interatrial septum, now with a solid rim, but with liquid in its interior. Another TEE example of an aortic valve with endocarditis, where there is in this enlargement around the aortic ring with some echogenic area in its interior, typical of abscess. This was an intraoperative TEE with a huge abscess that started in the aortic valve and involved the anterior right atrioventricular annulus in all its extension. Another abscess that formed a fistula. This is a TEE long X view where you can see the communication of the aorta to the abscess, already empty, forming a pseudo-aneurysm and a fistula from it to the left ventricle. One more abscess that emptied in the right ventricular cavity and to the aorta, forming a fistula, aorta, right ventricle, across the abscess. You may notice also here this typical thickening of an early abscess. And what about this here? It's the right pulmonary artery. No abscess. Notice this enlargement of the mitral valve leaflet, seen in a two chambers TEE view. It's still mostly solid, but with same liquefied regions in its interior. This kind of abscess often leads to mitral regurgitation by forming a fistula from the left ventricle to the left atrium. 3 more cases with abscess, already liquefied, forming an aneurysm of the mitral valve. Notice here that there is another abscess, yet solid, being formed in the posterior leaflet of the mitral valve. Another example. Notice that it is not a rare situation. Look at this case. The anterior leaflet of the mitral valve seems to be prolapsing, but at close inspection, you notice that it is an abscess with a fistula to the left atrium. The mitral regurgitation first fills the abscess cavity and then goes to the LA. As the ultrasound beam is large, you can see in the TEE of this patient the region of the leaflet not involved by the abscess and the abscess cavity, now a mitral aneurysm. Another complication is the valve perforation, more often seen in patients with aortic valve endocarditis, who has an infected regurgitation jet directed to the anterior mitral leaflet. It forms a tiny abscess that ruptures, creating a fistulous mitral regurgitation. One of the most frequent complications is the ruptured chordae of the mitral valve. Here we see that the rupture is quite obvious, with an important mitral regurgitation. Question is how to be sure it's only ruptured chordae, or if there is also vegetation in this leaflet. Notice that if the vegetation is small, you cannot distinguish it by 2D echo. However, the M mode is quite different. Look how the mitral valve has an aspect of smudge and also of ragged paper. So this demonstrates it's not only some rupture chordae, but also infectious endocarditis. See the importance of M mode for this diagnosis? Here, the transesophageal echo showing the ruptured chordae of anterior leaflet that moves inside the left atrium beyond the posterior leaflet border. Even here it is hard to be sure if mild thickness seen at the border of the anterior leaflet is a vegetation or not. There are some features in the vegetations that may be helpful concerning prognosis of possible rupture or emboli. One of these prognostic value signs is the location of the vegetation. If there is one single vegetation in a single leaflet or cusp, the prognosis is better than more than one vegetation. It is a worse prognosis if more than one leaflet or cusps are involved, and worse yet if besides a valve there is also vegetation in the cardiac walls. The echo density of the vegetation has also prognostic importance. A brighter echo density than the walls indicates calcification and may not have any inflammatory activity, and hence a better prognosis than a density similar to the myocardium. Since when the density is similar to the myocardium, it is usually seen in a more friable and recent vegetation. Considering the vegetation motility, it may be sessile, better prognosis, grade 1, sessile but with motility only at its tip, grade 2, pedunculated, grade 3, and pedunculated with prolapsing from one cavity to the other or from the aorta to the left ventricle, grade 4. In relation to the size of the vegetation, you see that complications are much more frequent when it's larger than 10 millimeters. The echo follow-up of a patient with endocarditis is mandatory. The vegetations may get larger during treatment, not because of worsening, but only due to deposition of platelets or fibrin. Then what we should be aware is the clinical response to the treatment, not if the vegetation has enlarged. A progressive valvular destruction with worsening regurgitation is an indication of a persistent infection. An abscess may be developing during patient clinical improvement. This is an incredible case that shows how we should follow these patients. This was a 13-year-old girl who had a clinical suspicion of endocarditis, and this here is her first echo study. Notice that there is no sign of vegetation in the mitral valve, even in a careful scanning with a mode of this valve. For Chamber's apical view, no problem in this valve. As a matter of fact, all the structures were normal. And watch here the date, December 2, 1987. In our report, we said is a normal echo what does not rule out a diagnosis of endocarditis, and to return within 1 week if the possibility of the same diagnosis persists, to check if then we could see any vegetation, what would seal the diagnosis, or earlier than 1 week if any change in clinical evolution. That's the correct procedure if a TEE is not available, and it was not at that date. Today, it would be indicated a TEE to any patient with clinical suspicion of endocarditis who has a normal transthoracic echo. In case the TEE also is found normal, it would do the same recommendation as before. Return in 1 week if the suspicion persists. But anyhow, in this particular case, the patient returned 2 days later. Look at the date, December 4th. This patient now had a huge vegetation in the mitral valve with rupture chordae and acute mitral regurgitation, and had to go straight to surgery for a valve replacement. Remember, always, never rule out a diagnosis of endocarditis by echo.